Recently, I attended one lecture of the endocrinologist regarding Fineronone. Fineronone is a non-steroidal mineral receptor antagonist, and the role of Fineronone is mostly in chronic kidney disease and in resistant hypertension. They say that there are four pillars to treat the kidney disease, especially the chronic kidney disease. The first one is the RAS inhibitor, that is the renin renin-angiotensin system inhibitors. The second one is SGLT2 inhibitors. SGLT2 inhibitors are anti-diabetic drugs, and they are mainly used to decrease the albuminuria, and they are not preferred in type 1 diabetics. The third one is GLP-1 antagonist, that is the glutides. They are also anti-diabetic medicines. And the fourth pillar is non-steroidal mineral receptor antagonist, that is Finerenone. In any heart failure, ejection fraction can be either preserved or decreased, that is, there can be a diastolic dysfunction, which further leads to congestive heart failure. What is the main side effect of the mineral receptor antagonist is increase in potassium, and when the potassium increases, there is always a chance of asystole, that is the serious adverse event can happen after potassium increase because of the side effect of mineral receptor antagonist is asystole. But we should remember that even the RAS inhibitors, that is the angiotensin receptor blockers and ACE inhibitors, also increase the potassium. So when we are giving both the drugs together, there is high chance of increased potassium, and the adverse effect event chances are more, especially the asystole. In the mineral receptor antagonists, eplerenone has a lower risk of increasing potassium. Eplerenone has a lower risk of increasing potassium. Uh, it has been found that hospitalization for heart failure has decreased since we have started using uh, proper potassium monitoring to monitor these side effects. To monitor these side effects. Next, we come to what is CKD in diabetes. What are the features? In whenever there is a CKD in diabetes, we should look for microalbuminuria. We should look for a glomerular filtration rate, and when there is a CKD in diabetes, SGLT2 inhibitors are overexpressed, and this leads to more glucose in urine. What happens in CKD is phase. In the initial phase is the hyperfiltration phase, and in this, the glomerular filtration rate reaches 150, though the normal GFR should be around 125, and then that glomerular filtration rate then decreases, and proteinuria increases. The normal fall in microalbuminuria, normal fall in the albumin in urine falls by zero point 0.5 to 1 ml per minute per year is the normal decrease in eGFR. So whenever patient comes to us, we have to do KDCO classification of the CKD to see the severity of the CKD, and if the patient is, we will go to KDICO classification of CKD. In the end, there is one formula of CKD epi formula which we can use to calculate the eGFR in CKD patients. We should always remember that whenever a patient comes to us, that we have to do eGFR levels and urine albumin creatinine ratio at least once a year, because sometimes eGFR is normal but UACR is fully abnormal, and we might miss the kidney involvement just looking at eGFR. Spironolactone is a mineral receptor antagonist which is used for resistant hypertension, and Finerenone, the non-steroidal mineral receptor antagonist, does not have any role in resistant hypertension, because it does not decrease or increase the BP. Spironolactone has an effect on BP. For the patients with type 2 diabetes with CKD, Fineronone has been approved. Fineronone has been approved by FDA, by DGSA both. And at 4 months, we have seen that urine albumin creatinine ratio decreases in the patients on Fineronone. Albumin decreases by around 30%, and this decreases the CKD progression. There is no change in HbA1c, that is, Finerenone does not have any effect on diabetes. But what is contraindicated when we are taking Finerenone? All the things which are rich in potassium are not to be taken. For example, dates, bananas, coconut, milk, fish, other non-veg. Moderate liver disease is a contraindication. We don't have to give Finerenone when eGFR is less than 30 or the patient is on ACE inhibitors and angiotensin receptor blockers. We start Finerenone in patients with type 2 diabetes and CKD when potassium is less than 5. eGFR is less than 60, we give 10 milligram, that is a half dose. More than 60, we give full dose of 20 milligram, and then we monitor potassium at 1 month. If it is normal less than 5.5, we increase the dose. If we have started at if we have started at 10 milligram or 20 milligram, and we increase the dose by 10 milligram. If the potassium is increasing, that is, it is more than 5.5 and the patient has hyperkalemia, we may temporarily stop the medicine. This is the KDICO classification of the CKD, in which there is a risk of CKD progression, frequency of monitoring and referral to the nephrology according to the GFR, and albuminuria is told. So the rows show the GFR categories in ml per minute per 1.73 meter square, that is the body surface area, and it is divided into 5 stages. The glomerular filtration rate, and normal is more than 90, and the severely decreased is less than 30, and the mild to moderately decreased is divided into G3A and G3B. The albuminuria categories are divided into A1, A2, A3 depending on the albumin released in the urine based on UACR, that is the urine albumin creatinine ratio. When the urine albumin creatinine ratio is less than 30, it's A1, UACR 30 to 300, it's A2, and UACR more than 300, it's A3. And then using this special table, we know that all the values which fall in this red have to be referred and treated. All the values which are in orange should be treated with macroalbuminuria. With macroalbuminuria, also refer to the nephrologist. And the patients who have everything normal and eGFR is only mildly decreased and UACR is less than 30, we just have to screen them annually. And we had an CKD API formula, that is the CKD PI formula, and what it uses the gender, it uses the age and the creatinine level to calculate eGFR. And the formula is the final equation is eGFR is equal to 142 into the minimum, that is the standard creatinine, divided by K constant into 1 proportional to alpha into the maximum, that is the standardized serum creatinine, divided by K into 1 proportional to minus 1.2 into 0.9938 and raised to the power age in years into 1.012 if female, and not to multiply this 1.012 if it's a male patient. And this helps us to calculate eGFR properly.